Let me start off by showing you the case profile of one of our patients. A 35-year-old came for a second opinion for glaucoma. No systemic illness, no family history of glaucoma. He had a best corrected visual acuity of 6.6 and N6. Cornea adjusted applanation pressures were 26 and 32 millimeters of mercury. Shallow chambers, and you can see the dipping of the beam here, the peripheral convexity. Angle is open, but you have patchy pigment on shawl base line here. So the diagnosis for us was primary angle closure. This is what the optic disc looked like. Right eye. This is what the optic disc looked like in the left eye. Our working diagnosis was primary angle closure. We asked for fields, and the right eye was normal, just to show you the discs. But the left eye showed a marked change on the nasal side, extending superior temporally, on the superior hemisphere and also on the inferior hemisphere. But it did not match with the optic disc, that change that we were expecting. We had done the HRT, the right eye was normal, and the left eye showed a change which did not match with the expected clinical examination of the optic disc. I'll leave this here. We'll come back and discuss this a little later. I'm going to talk to you about congenital anomalies of the optic disc because these are mimickers. And for many reasons, they'll either fit into a glaucoma picture or not fit into a glaucoma picture. And they've been classified variably. The important thing is the average size of a disc is about 2 millimeters square. So if we were to see an optic disc less than 1.5, we'll start thinking the rules that we discussed, and that small size optic disc should have no discs. Look at this picture. How many people would say that this is a glaucomatous optic disc? How many people would feel that this is normal? Okay. Now I want you to observe that on the red free there is a nerve fiber layer defect which is present superiorly. You can also suspect a nerve fiber layer because of the prominence of the superior vasculature as compared to the inferior vasculature, because this is a sign of a nerve fiber layer defect. You also find that there is what we call as a double pigmentation, a double ring sign, because of the bare sclera seen here, surrounded by an area of nerve, surrounded by a retinal nerve fiber layer area. Look again at the prominence of the blood vessels superiorly as compared to in the lower part. And when you look at this, you find that there is a thinning of the superior nerve fiber layer, and you find that there is a double ring sign. Now, when you have a superior structural change, if you do any of the imaging instruments, we did the GDX, the OCT and the HRT, and there was a superior change happening in all these optic discs. So if there was a reproducible, confirmed superior structural change, the visual field should have also shown a change, and the Humphrey also showed a change, and the octopus print machine also showed a similar change. So here was a patient who had a structural change, who had a demonstrable functional loss. So if you apply your definition for glaucoma, are you convinced that this is a glaucoma now? Right. So here's the key. This patient had what is called as a superior optic nerve hypoplasia. It's a congenital anomaly which becomes a mimicker of glaucoma because it presents with a nerve fiber layer defect and a demonstrable structural and functional change, but typically this change will be non-progressive. So like us, you could start this patient on treatment and then realize that with and without treatment there is no difference in intraocular pressures or the progression of the disease. You might come back and do a trial with stoppage of treatment and find that the patient is still doing well and revise your diagnosis. So typically superior optic nerve hypoplasia is more common amongst the various patterns of hypoplasia. It's associated with endocrinal anomalies and CNS malformations, typically seen in, this is another of our patients where we picked this up. And you would find it in mothers who indulge in alcoholism during pregnancy, insulin-dependent mothers, and typically the diagnostic criteria is a diminished intracranial part of the optic nerve, similar to features of a septic optic dysplasia. That's what you actually got to look for. So small size optic nerves can be associated with a optic nerve hypoplasia, and the commonest variety that I have picked up in my practice is only the superior one. I'm sure I must have missed some other varieties, but that's what I picked up. Now, amongst large size optic discs, anything larger than 2.5 is megalopapillae. There are two variants of a megalopapillae, one which is bilateral and therefore easier to pick up. But the problem is when you see the type 2, because it's typically unilateral. And being unilateral, compare with the other side, you'll find all your rules of optic disc examination not conforming to this, and you're more inclined to think in terms of glaucoma. But they are a congenital anomaly. Do the fields and you'll get good answers. Typically, megalopapillae can be associated with some CNS malformations. So it's always good to have the pediatrician look at the child and get some sort of a radiological imaging of the brain. Tilted discs is again what we commonly see. They are bilateral, not inherited, associated with a fair amount of mild to moderate myopia. Typically these discs are tilted inferiorly and nasally, and the blood vessels usually arise from the temporal side. This is a disc with a mild tilt. You will also find that there's a small area of RPE atrophy associated inferiorly. Do the visual fields and you'll find a refractive scotoma on the temporal side. Repeat the fields with a -4 diopter sphere and this refractive scotoma will disappear. It's all a refractive change. And tilted discs are what is, you need to follow them up carefully over a period of time, because the other thing is, if you do any of the newer imaging modalities for tilted discs, like whether it's a GDX or an OCT or an HRT, they will always be diagnosed to have disease. Are we together on this? In fact, this will happen for most of these congenital anomalies of the optic disc. The newer imaging devices will pick them up and identify them as disease. Look at this. It's a typical morning glory syndrome. It's a large size disc. It's an excavation of the optic disc, large in size, surrounded by a peripapillary area of hyperpigmentation. Lot of glial tissue giving rise to the yellowishness of the optic disc. Look at the peculiar branching of the vessels that you see here. It's so called because it resembles a morning glory flower. And then there are atypical varieties. It's not a classical morning glory here, but a form fruste variety, and they're often associated with the hemangioma of the face and arterial and cardiac anomalies. Another form of a congenital anomaly is a coloboma of the optic disc. Typically, you'll see the coloboma inferiorly. There could be an associated retinal choroidal coloboma, a lens coloboma, or a iris coloboma. And you know, they can produce field effects in the superior hemisphere, making you think in terms of a congenital, thinking in terms of a glaucomatous anomaly. So you got to be very careful about this. Just to show you the various, so if you identify this as the size of the margins of the optic disc, then obviously you'll think in terms of this being an inferior notch, but actually the disc margin runs somewhere here. Peripapillary staphylomas typically, they're normal or large size excavations, excavations surrounded by an area of depression. You'll see them in myopic discs, and this is again which will create the doubt in your mind. Do the fields. Myopic discs, again imaging devices will not work. It's your fields which will show a change, which will usually be non-progressive, and the myopic fields will usually show you a change on the temporal side. So that will again become a confounder. Are you looking at a neurological abnormality? But typically myopic discs are unlikely to progress over a period of time. The other thing you'll see is a pit. And an optic disc pit is a pea-sized swelling that you will see on the optic disc. It usually temporal, but you could find them at various locations of the optic disc. Typically, pits of the optic disc will be associated with some form of a CSR. So mind you, if you're taking up patients with an optic disc pit for surgery, you would not like to drop the pressure too low, because if you drop it, the macular thickening will increase. So you got to plan these things out for your patients. Drusen's of the optic disc. They are accumulated calcified material giving the appearance of a mottled appearance to the optic disc. Typically, you'll find the optic disc margins blurred. Children will have lesser blurring, but it will appear to be elevated because of the deeper presentation of the calcified material. The diagnosis is best made when you do a B scan. You'll find 100% reflectivity in the region of the optic nerve, corresponding to the calcified material. Even a CT scan for that matter should pick up the scan. So I'm coming back to this case profile that I showed you, a 35-year-old who came for a second opinion, no family history of glaucoma, no systemic illness, vision of 6.6 and 6, cornea adjusted applanation pressures are 26 and 32 millimeters of mercury, shallow chambers, occludable angles. Look at the disc. Look at the temporal margin of the optic disc, not well defined. Our clinical suspicion was in the form of, I'm making a clinical diagnosis here of a drusen of the optic disc. And you know, the fields didn't match with the expected optic disc change. We got the B scan done and it showed 100% reflectivity in the vicinity of the optic disc. This was a diagnosis. But we were still not able to explain the marked pallor. We got an MRI of the brain done and it showed encephalomalacia for this young man. And encephalomalacia was absence of parts of the brain. This patient didn't come back to us for a laser PI in view of his angle closure. He didn't actually go in for any medical treatment except the eye drops. But I just thought I'll show you this picture. An optic disc change, we thought it was drusen and it was confirmed as a drusen, but we got radiological imaging of the brain because of the marked pallor and the disproportion with the fields, even though they were not temporal field effects that we were seeing, and we picked up the encephalomalacia. You could often see myelinated nerve fibers here. They're very fine here, and I'm purposely showing you the finer ones and not the gross ones because I want you to realize till you actually look at these things with something in mind, you'll never pick them up. I mean, it's not like you sweep through the optic disc and you'll pick it up. You have to ask yourself, did I look for something which is not matching? Did I look for something which seems to be out of place? That's when you'll pick up most of these findings. And then you can pick up this pigmentation of the optic disc which is there. So again, just a reminder, when you're looking at an anomaly, particularly a congenital anomaly of the optic disc, it's your visual fields which will help you to move forward. And usually never the newer, not new now, the imaging devices will produce false positives. The red disease is going to be seen here. So be very careful in asking for investigations. It's better to ask for a radiological imaging of the brain when you see a congenital anomaly than ask for an OCT. Thank you very much.